those of you who don't know me, I'm Vince. I'm a PGY4. I am going to be talking about clinical informatics today. Surprise, surprise. So first of all, I have no financial disclosures. This one's for the attendings. If they want to donate to my coffee fund, this is my Venmo. This is my Zelle. We are going to start with defining clinical informatics. So if you guys want to just throw out some terms, some phrases of what you guys think informatics is. Aside from me. Nice, nice. Anyone else? Okay. Anything else? Nice. All right. We can continue. So I will start with what informatics is not. It is not just being your IT guy, not just about coding or being your data guy. And it's not just about being an AI guy. Most importantly, it is not about being your Epic guy. So what is informatics, right? It is a whole slew of things, including data, which includes analytics, HIPAA compliance, the EHR, so developing and optimizing systems that stores and manages PHI, as well as interoperability, right? So making sure that systems talk to each other, and clinical decision support systems, things like MD Calc, OPAs, things that help us use evidence-based medicine in our daily practice. QI, so improving workflows, throughput, and streamlining processes, and devices. This includes AI, this includes wearable devices, but at the core of it, all of this is focusing on patient safety, patient outcomes, and healthcare delivery. So the TLDR essentially is, it is a cross-section between data, people, and systems. This is one of the fundamental theorems of informatics. It's the idea that humans are always prone to error, but humans with an information resource will always be better than the human alone. At the core of it, because our goal is to help people, if your resource isn't helping you do that, you should modify the resource to make sure it does. So why does this matter? This was a study that looked at EDs, patients who came through the ED. It was about 2,000 patients who came through an ED in Michigan. And they looked at a health information exchange. So this is basically like a cloud or a centralized location where information would pass through, basic patient information, and it could then be redispersed to other sites, other locations easily. Right? So what did they look at exactly? What they did was they had a clerk who, after the clinicians put in an order, they would get information on the patient via Care Everywhere or a manual fax and scanning into the EHR. Obviously, what they found was Care Everywhere was much faster by 51 minutes, okay? But for every 1 hour reduction in access time, they had a decreased length of stay, they had decreased likelihood of imaging. So CT was about 7% lower, MRI was 18% lower, and X-rays were 4% lower. Decreased likelihood of admission by 4%. And it was cheaper for the patients overall by about $1,200. This was all statistically significant. This was a study that Stanford did at their children's hospital. So a computerized physician order entry system is essentially an EHR. So what they did was they upgraded from paper to an EHR. And what they found was that they decreased their mean mortality rate by a sizable amount after they implemented the EHR. So it was 20%. That is pretty big. This was a study out of Yale where they did a pragmatic cluster RCT in 2022. It involved a user-centered clinical decision support tool on BUP initiation in the ED. This was done by Ted Melnick. He is essentially the head honcho of EM Informatics. They had about, I believe, 1 million or so patient encounters to sift through. This was at various EDs throughout the US as well as parts of the UK. So they built an app that was integrated into the sidebar of Epic, and clinicians would open up the app and it would so they didn't have to alt tab out. What it did was it identified appropriate patients, it avoided workflow disruptions, and it streamlined documentation so that clinicians were able to do everything all from one window. And it also helped them understand the treatment process. Overall, they didn't find any statistically significant BUP initiation. However, more physicians in the intervention arm, so the ones who use the clinical decision support tool, initiated BUP compared to the control arm by about 10% more. Currently, Yale actually uses this as a very rapid way to roll out new clinical workflows and protocols because they don't have to go through their version of like a larger like organization group or a work group to get approval because the app itself is already approved. Now, how do we get here? So we have to rewind a little bit and have a little bit of a history lesson. So back in 1999, there was a report that was published by the Institute of Medicine on medical errors. It was called "To Err is Human: Building a Safer Health System." What it said was medical errors are a significant cause of morbidity and mortality, affecting patient safety and quality of care. We need better systems, communications, and training, and that will help reduce errors and improve patient outcomes. We need to adopt a culture of safety, better technology, and ongoing education for healthcare professionals to minimize risk with medical care. And we need to have a systemic approach to address challenges in the healthcare system. In 2008, this was the economic recession, which was fueled by the housing market. But the following year, in 2009, there was an American Recovery and Reinvestment Act. This was a stimulus package aimed to create jobs, promote economic growth, and stabilize the economy with $831 billion in spending and tax cuts focusing on infrastructure, education, renewable energy, and healthcare. And so part of the healthcare was the High Tech Act. Okay, this was $25.8 billion for health information technology investments and incentives payments for EHR adoption and something called meaningful use, aka organizations as well as offices had to show how they're using the EHR to improve patient care and outcomes. And if they didn't, they would get fined. There were a few key factors. Essentially, it was adopt EHRs, strengthen privacy and security for health information, develop health information exchanges and promote interoperability, and foster creation of accountable care organizations to coordinate care and improve health outcomes while reducing costs. Essentially, organizations or clinicians that adopted EHRs and complied with the CMS rules on meaningful use led to financial incentives. Otherwise, they risked penalties, including reductions in Medicare reimbursements. I believe the magic number was 3%. And so if you can imagine how many like millions or billions of dollars a large healthcare system made, if they lost 3% of that, that would be massive. After this, in 2011, clinical informatics was born, the subspecialty, by the American Board of Preventive Medicine. And in 2014, Stanford becomes the nation's first ACGME accredited CI fellowship. This same year, there's also increased EHR adoption and interoperability initiatives, including development of a new standard of health information called FHIR, otherwise stands for Fast Healthcare Interoperability Resources. Essentially, this was a standard where patient information could be submitted and they would standardize this information across all these various EHRs, all these different apps, so that all these apps could access it very quickly. And this is how Care Everywhere, as well as all these other health information exchanges was born. Now, in 2016, there was another act that came out called the 21st Century Cures Act. This helped increase funding for biomedical research, expedite approval processes for drugs and medical devices, support for mental health services, and continue to push for interoperability. So that brings us to today, 2025. So where are we at? This was a report done by the Class Arch Collaborative. It's a healthcare IT research organization who analyzes EHR vendors and polls physicians and healthcare organizations. This was their 2025 report. And as you can see, Epic is essentially leading the charge. But in the future, there could be a different vendor, and that's why Informatics is not just about Epic. This was part of one of their 2024 reports on interoperability. And the big takeaway here is that physicians are still mostly angry about interoperability, data access, and documentation. I'm just gonna keep going. So where do I think we stand? So I think, years ago, we were in clinical informatics 1.0, which was establishing EHRs, laying the foundation, right? Transitioning over to Epic, transitioning over from paper to Cerner, et cetera. So this is Internet Explorer, the OG. And now I think we're currently in clinical informatics 2.0, right? This is Microsoft Edge. So we have to continue working on interoperability, improving user experience and interfaces, and integrating AI and devices. Where do I think my crystal ball is taking us? So this was a study that was just released from Tampa General Hospital. This was a QI project. They wanted to use AI to reduce length of stay in the neuro ICU. This was their magic question. What are the clinical barriers preventing patients from being downgraded? How can we get these patients out? They defined 76 clinical criteria. They did not list the criteria in the study, but what they did was in multidisciplinary rounds, all the presentations, all the info was standardized. And so the AI analyzed it and they split it into two groups. It's either no criteria were met, no bed requested or assigned, or greater than or equal to 3 criteria were met. And if they fit into one of these two groups, the AI either flagged the patient as ready or not ready. Unfortunately, they didn't mention what happened to the patients who met some criteria between 1 and 2 criteria. But 6 months out, what did they find? There was a pretty large reduction in the ICU length of stay, 8 hours. Placement of transfer orders occurred 3 hours earlier, so not waiting until after rounds. And most importantly, there's no change in bounce back. So they didn't have any adverse outcomes, even though they sent these patients out sooner than anticipated when there wasn't an AI to help them dictate this. So how do I think this can help us move forward? This is a slide taken directly from ACEP's boarding crisis homepage. I think we're here, the unfortunate reality of being in the middle of a nationwide boarding crisis and overcrowding. I think if we can use AI to help move patients through the hospital, we can help relieve some of the burdens of this. Okay, I think this is truly the million-dollar question, the billion-dollar question, honestly. I think if we can get laminar flow of patient throughput, then we will solve a lot of these issues that come from patient boarding. So I put a prompt in ChatGPT. Oh, let me see if it pops up. Okay, so I wrote, generate a photo of a person who uses AI as a flow manager for hospitals. Their role is the quote bed czar, and they help move patients throughout a hospital from initial admission from the ED all the way until discharge. They should be wearing a czar hat. And so this is what ChatGPT thinks, right? A little bit of a long neck, but otherwise, I think it looks okay. So how do you get involved, right? Where do you even start? So this is AMIA, the American Medical Informatics Association. This is essentially the premier association where all the publications are. They have a pretty old, antiquated looking forum where a lot of people from around the country still post. This is where all the latest research is. This is Epic Training. So we all have access to this for free. There are a lot of different classes that you can sign up for. What I would recommend people do is if you're interested, take some of the smart user training. This is how you get more proficient with Epic. You don't have to get certified. You can just take classes just to take classes. If you want to do deeper dives into, the back end of Epic and kind of learn how to create a lot of different order sets and get more involved, then I recommend you go for physician builder training. That you will need approval from Dr. Peacock. But there's a lot of classes, including slicer dicer, custom filters, and etc. This is a medical industry trade newsletter that's free to subscribe to via email, so you can stay up to date in the healthcare admin/finance and IT related space. And I didn't talk about industry to industry. MD Plus is a nonprofit organization run by medical students who are aspiring physician innovators. It was actually started by an EM resident at Stanford who has been very heavily involved in the health, biotech, and consulting field. They often, so on their Slack channel, they will post offerings for internships at like different like VC companies and whatnot. So it's actually a pretty big deal if you're interested in going into industry. So summary, informatics is a workflow specialty. Humans and information resource is better than a human alone. And the practice of medicine is drastically changing. Definitely embrace it. That is the gist of it. And a couple of dedications. So thank you to Drs. Peacock and Youssef, who have given me freedom to explore my niche while helping me better the department and backing me up on administrative/informatics meetings. Especially shout out to Dr. Peacock, who has had an endless amount of support by always being available to reach for my silly questions, adding me onto a lot of different projects, informatics education, and essentially swooping me in under his wings as a future informatician. This is my family. They have supported me in all of my endeavors. My sisters and their little ones, they have kept me up to date on the latest lingo like skibbity toilet and what the sigma. Shout out to my mom who never forgets to give me plenty of fruits and vegetables every time I go home, even though I live down the block from Whole Foods. And my dad, who taught me the meaning of grit when he immigrated here with nothing more than 2 feet and a heartbeat. Worked for 2 decades at the same restaurant for 12 hours a day, 6 days a week to put me and my 2 sisters through college and grad school. To my love, the mother of our 2 fur babies, the one who understands me and inspires me to be a better doctor and person on a daily basis. She's the one who teaches me how to manage diabetes on OBS, listens to me vent about consultants, tells me my cooking is good, and laughs at all of my jokes even when they're not funny. These are the sad fur babies. The tux is Zuko, and the tabby is Cora. And then this is, yeah, sometimes they get along, but we're just videoing them at the right exact time. And finally, to my second family, I have 3 things to say. It's not goodbye, it's see you later. One more button. And may we forever live on as the objectively best class county has graduated. That's it.